Hey guys, so this is part 3 of the final review. I'm going to start with rhythm identification and troubleshooting. There will be 5 questions on this exam about this subject. They've broken it down into lethal, common, and nursing care for both of those. So I'm just going to go through our chapter. I'm starting on page 90. And I'll be flipping through, talking about the rhythm and its treatment together. So first up is sinus bradycardia. This is treated with oxygen. You're going to start an IV and put them on telemetry. If it progresses to be worse and need medication intervention, this we'll use atropine, epinephrine, or dopamine to treat sinus brady. So sinus tachy is the next common rhythm. For this one, they're going to try and treat the underlying cause, but they're going to treat the underlying cause. They're going to set up an EKG and start an IV. So the next one we're going to talk about is SVT. This one is a lethal rhythm. The treatment for this is adenosine. It's the first line drug. And then if it becomes worse, then we can use synchronized cardioversion. The next one is atrial flutter. It's a common rhythm. The treatment for this is calcium channel blockers or beta blockers. We can also use amiodarone or synchronized cardioversion for atrial flutter. Atrial fib, this one, they're going to be put on a blood thinner because AFib lends to blood clots. Then if they can't get it back under control, they will treat it with cardioversion, synchronized cardioversion. And there are some procedures they can do to fix AFib as well. Moving on. I'm skipping all the blocks, mainly because my brain just doesn't have room for that. So now we're going to talk about VTAC. VTAC is the tombstone appearance. It is treated with amiodarone, procainamide, or sotalol. You can also synchronize cardiovert this rhythm. And if your VTAC becomes torsade de pointes, magnesium is the treatment for that. Ventricular fib, you always defib the VFib. That is the treatment. CPR, all the things. Defib the VFib, okay? Asystole, we're going to do CPR, 5 rounds of it, and after that you need to either get the family in there so then you can stop, or the doctor can call the stop. Then we have PEA, pulseless electrical activity. This is also CPR. If you get a rhythm back, you shock it and treat it from there. So while we're here, I didn't cover pacers in the last video, and I said I would do it this video. So this is in that same chapter on page 113. You've got temporary pacemakers. The transcutaneous, that's the pads that you stick on. Most defibrillators can do transcutaneous pacing. Then you have transvenous or epicardial pacing. This is internal. It's inserted and attached to the heart, and it's temporary. And then you can have the permanent pacemakers, where they insert the pacemaker generator into their chest and thread the wire down to the heart. For modes, we have demand, where it is synchronized with the patient's heart rate and only paces when necessary. We have a fixed rate, where it fires consistently at the same rate, doesn't matter what the patient's heart rate is. Then we have some malfunctions that we'll cover real quick. We have failure to pace. It's just when the pacemaker doesn't deliver the shock. Then we have failure to capture. That's when it fires, but it's firing at the wrong time and it's not allowing for the heart to depolarize, so it could be dangerous. And then failure to sense is when the pacer doesn't recognize when it needs to fire. And so it looks a lot like the failure to capture. I take that back. Failure to capture is the patient's heart is not reacting to the electrical stimulus. And failure to sense is when the pacemaker is failing to fire. So, implanted pacemakers can also be defibrillators. So we're going to move on to vents. There are 8 questions over vents. I'm not going to talk about the tracheotomy. If you would like to review that, we did it at SimLab, the care for it. Yeah, I'm not doing that. There's so much other information to cover. So pressure support and PEEP. This is on page 65. So your PEEP is your positive end expiratory pressure. We want to keep that between 3 and 10. The PEEP is the pressure remaining in the lungs after exhalation. It holds open the alveoli and allows for when they do breathe that those alveoli are fully expanded and facilitating gas exchange. If you do increase the PEEP greater than 10, we just really have to watch for barotrauma to the alveoli, and we're going to monitor blood pressure because that increased pressure of your thoracic cavity can press on your vena cava. So pressure support is the opposite of PEEP. It occurs at the beginning. It occurs in right before inspiration. What it is that the machine will push air into your lungs so that when you do take a breath, it's easier for you to breathe because there's not, think of it as like a balloon. So when you first start blowing on the balloon, it's really hard and then it gets easier. That's the same principle as pressure support. So the machine is doing the hard work of blowing up the balloon, your lungs, for you, and then you just get to take the breath. That's what pressure support is, and it's used often in the weaning cycle when they're being taken off of mechanical ventilation. So for safety on vents, we're gonna do the VAP precautions. It's like a little bundle that they taught us where you do oral hygiene, you know, with the chlorhexidine, you do the suctioning, all of those precautions we take to prevent the ventilator-associated pneumonia. Airway maintenance, this is the suctioning, which we'll talk about in further detail in a minute. Restraints so that they can't pull that ventilator ETT tube out. Education, we're going to educate the patient and the family. Sedation, they used to require, like, suggest that sedation was like absolutely necessary with a ventilator, and that it did no harm to the patient. But what they're finding is that it can do some psychological harm to the patient. And so now we are trying to walk that fine balance of the patient being able to hear us and understand what's going on, but not wake up enough to be in a lot of discomfort or trying to remove the mechanical ventilation. And then we're also going to provide nutrition through the either an OG or an NG tube, because obviously they can't eat the normal way. Then for suctioning, this goes with your airway maintenance. And there's really 3 steps to this, and it's not hard, but you just got to make sure you do it. So we're going to hyperoxygenate our patient with a push of 100% oxygen before we suction them. Then we're going to immediately suction them. This should not last more than 15 seconds. And then we're going to hyperoxygenate them following the suction. And this is to prevent hypoxia and promote comfort in the patient. So now we're going to talk about trauma. There are 5 questions over trauma. You got your primary survey, your airway, breathing, circulation, disability, and expose. So airway is like, ask them their name. If they can talk to you, they have an airway. If they can't talk to you, look, is their throat closing? Are they breathing? We can see that from across the room. Is their breathing adequate? Make sure that you check their pulse ox and stuff. Circulation, cap refill, are they actively bleeding? Skin turgor, things like that. Disability, what's wrong with them? Where's their injury? What's going on? Expose, this means trauma naked, guys. You can't know what's going on with them unless they are nude, okay? So strip them down, look them over, don't miss anything. Your secondary survey continues down the alphabet, so you have your full set of vitals, give comfort measures, history and head to toe, and inspect posterior surfaces. So I feel like those are pretty self-explanatory. I'm not going into further detail on those. Then they have to review your ABCs again, but we just did it, airway, breathing, circulation, in your primary survey. So moving on. Blunt versus penetrating trauma. We have blunt. That is where the skin remains intact and you have extensive damage underneath the skin. It can be like a huge hematoma. It could be internal bleeding, broken bones. Doesn't matter. If the skin didn't break, it's a blunt trauma. Penetrating is an open injury, which just disruption of the skin. So you can break an arm and the bone come through. Stab injury, gunshot wound, penetrating. If the skin broke, it's a penetrating trauma. So common traumatic injuries that we've got right here, review the nursing care on these, but we've got pneumothorax, which is air compressing your lung, hemothorax, which is typically blood, but other fluid possibly. So blood compressing your lung. Flail chest, that's going to move opposite of, so like if you're breathing in, your chest is supposed to come up, theirs will look like it's going down. And if they're breathing out, their ribs will pop out. It's due to a break in your rib cage. Shock, typically hypovolemia. You can get other kinds of shock as well, but that'll be the most common. Cardiac tamponade and compartment syndrome are the other ones that we've got going on here. So now we're going to talk about intracranial dysfunction. There's 3 questions over this. So nursing care related to ICP and monitoring. The biggest thing with this is that we are going to prevent infections by using the aseptic technique every time we touch this system, okay? This is a big deal. That goes straight into their brain. Infection is a huge deal when it comes to this, okay? So then the nursing care is on page 245. I'm just gonna run through it real quick. Hourly neuro checks, monitoring MAP, ICP, and CPP, because this can guide fluid replacement and other interventions that the doctor might order. Then we're going to validate that our ICP is accurate. So it's a lot like an art line. We have to maintain the system, level it, zero it, make sure it's giving us accurate information, troubleshoot it if it's not, the aseptic technique, and changing the dressing. It needs to be clean, dry, and occlusive. And anytime it gets damp, it has to be changed. And then if there's a CSF leak, that's the halo sign. Don't forget that. We will check the system for leaks and notify the physician because they have to replace that. We cannot replace that system. Causes of increased ICP. Your traumatic brain injury is the primary cause of increased intracranial pressure, but here's some others. We've got subarachnoid hemorrhage, hydrocephalus, brain tumors, stroke, and meningitis. Your traumatic brain injury is covered on page 250 through 255. I'm going to go over the things that I have highlighted. So what they found is that with the traumatic brain injury, management of the secondary injuries is vital to the outcome for these patients. So what we do is we intubate early, we transport them to an appropriate facility, and we do prompt fluid resuscitation. Then they get a CT scan. We will evacuate whatever is in their brain causing the injury and put them in the ICU with an ICP monitor. We're going to make sure they are oxygenated. We will give them lidocaine that will help maintain a low ICP. They're going to get a sedative hypnotic, a rapid-acting neuroblocking agent, so paralysis drug. This is all for intubation. Then it tells us more about suctioning, which we just covered, so I'm moving on from that. Basically, though, with the suction, you have to be really careful because it causes distress, which causes the increased ICP. Sedation and pain relief are essential for these patients because you don't want to raise their blood pressure, thereby raising their ICP. They have put patients in barbiturate comas. This has improved outcomes because it impacts the ICP. There's some nursing actions related to that, and if you would like to review those, they're on page 255. All right, moving on to gastrointestinal. There are 5 questions over this. The first section is alcohol withdrawal. Signs and symptoms of withdrawal are psychomotor agitation, anxiety, autonomic hyperactivity. This is tachycardia and diaphoresis. Increased hand tremors, insomnia, nausea or vomiting, or both. Transient tactile, auditory, or visual hallucinations, or tonic-clonic seizures. Only 2 of these things have to be present for them to be in withdrawal clinically. The management goals of treatment for this are to identify patients that are at risk, establish how severe their withdrawal is, decrease their agitation and prevent withdrawal progression, provide supportive care, maintain fluid and electrolyte balance. This can be orally, which we'll cover in a minute. Minimize effects on acute and chronic comorbidities. Goodness. Provide a safe and dignified environment, prevent complications, and initiate case management services for rehab later, once they're stable. The CWA is the most used scale for people in withdrawal. And for withdrawal, we do symptom-triggered therapy. So depending on their symptoms, we will treat their symptoms as they arise because there's not really any way to keep them from withdrawing from the substance. So for the meds that we'll give, we're going to give all the PAMs, guys. Benzodiazepines, lorazepam, I forget the other PAMs, but if it ends in PAM, It's probably used to help with withdrawal. They've had some success using propranolol and clonidine along with the benzos, and they used to use phenobarbital. Some people still do, but it comes with a lot of risk of its own, so it's not used widespread anymore. Fluid and electrolyte balance can be maintained orally if possible by encouraging them to drink fluids and eat. If they can't do that, we'll start an IV. Then potassium monitoring and supplements, they'll get labs ordered and med ordered for that. Magnesium can help with the tremors. Glucose labs, just to keep their blood sugar up high enough because they probably won't be eating. We're going to make sure these patients are safe. They'll probably be on hourly rounding, if not more often than that. They might have a one-on-one sitter. Then we're going to reduce stimulation. We're going to turn off the lights, close the door, not close the door entirely, but keep it quiet is the goal. And then they'll need a nutritional consult because a lot of times they are malnutritioned because all they do is drink. So now we have acute and chronic liver failures, the next section. Acute liver failure is most commonly caused by toxins and drugs, mainly acetaminophen, viral hepatitis, hypoperfusion, shock, metabolic disorders, and sometimes it happens and they have no idea why. For chronic, this, I don't really know, like alcohol abuse, hepatitis C, it will progress until you've got cirrhosis. We're going to, as nurses, we're going to do a fluid status assessment. Basically, anytime someone is sick, we're going to do a fluid status assessment because that directly affects your hemodynamics. Back to liver failure. We're going to educate them to abstain from alcohol and reduce their sodium intake. Then we're going to initiate diuretic therapy, fluid restriction, and if they've got ascites, we're going to do a paracentesis. If they have refractory ascites, they're going to get a paracentesis every 2 weeks. Now we're going to talk about portal hypertension. This is when scar tissue obstructs the sinusoids and blood flow in the liver, resulting in blood being shunted to the esophagus at high pressures, which leads to varices. Those varices can be clipped once they burst to stop the bleeding. Splenomegaly and ascites are also complications of portal hypertension. And portal hypertension is a complication of liver failure. Okay, guys, we're going to move on to the GI bleed section. For this one and the next one, I personally am reviewing more information because I didn't get to treat one of these in clinical and I don't see them frequently where I work. So I need more in-depth review on these, so that's what I'm going to do. Manifestations of a GI bleed are hematoemesis, which is vomiting, bright red blood, or coffee ground appearance. This is indicative of an upper GI bleed. You have melena, which is black tarry stool. It has that foul odor that I've heard some of you talk about. This is also indicative of upper GI. And then we have hematochezia, which is red or maroon blood in the stool. This is indicative of lower GI or a massive upper GI bleed. What we're going to do as nurses, we're going to assess the fluid volume status. Your vital signs are your best indicator. Signs and symptoms of hypovolemia. We've got hypotension. This indicates a blood loss of 40%. Narrowed pulse pressure, orthostatic hypotension. This indicates a smaller loss at about 15%. Tachycardia, EKG changes, chest pain. This one isn't necessarily common, but If your GI bleed is large enough, your patient can have a simultaneous myocardial infarction due to the amount of blood lost. We're going to check their cap refill. If it's greater than 3 seconds, that indicates hypovolemia. Poor skin turgor, flat jugular veins, decreased urine output, and mental status changes. For our lab values that we need to be reviewing for these patients, we've got your hemoglobin, platelets, electrolytes, BUN, creatinine, PT and INR, cardiac enzymes, liver function tests, and a type and cross. Nursing responsibilities, we're going to check their airway. If they're vomiting blood, their airway could become compromised. We're going to start 2 large bore IVs immediately if their airway is fine. Then we're going to start fluid resuscitation. After starting these fluids, the vitals should stabilize within 15 to 20 minutes. While we're doing this, we're going to monitor for fluid overload, and we're going to do a physical assessment. What we should find if they're having an active bleed are that their bowel sounds will be hyperactive. They will have abdominal tenderness. This can indicate ischemia, perforation, or an obstruction. They might have ascites. This is related to liver disease. And then we also need to be checking their stool frequency, color, and odor. The book talks about NG tube placement. This has become controversial, and they have found that it doesn't really promote any kind of difference in treatment. It doesn't tell you where it's at or what's going on. It can confirm some things, but it's just they don't use it very much anymore. We'll administer erythromycin because it stimulates gastric emptying before an EJD, or EGD, sorry. Proton pump inhibitors like Protonics, they reduce acidity in the gut, which facilitates clotting. So pre-op, before the EGD, we're going to maintain NPO status, get informed consent, remove dentures, get baseline vitals. We're going to educate the patient and their family. We're going to do the interventions as ordered, so like the erythromycin or the Protonics, or both, fluids, stuff like that. Then we're going to consult with the person doing the EGD and the respiratory therapist if your patient is being mechanically ventilated to coordinate how to get the EGD done while they're ventilated. Risk factors for rebleeds. Older age, comorbidities, hemodynamic instability, coagulopathy, and endoscopic diagnosis. What we're going to do if we have a high-risk patient is we're going to assess them slightly differently. We're going to assess their hemodynamics and fluid volume status frequently, their mental status and restlessness, pain and discomfort. We're going to check for hematoemesis melena and hematochezia frequently, and they're going to get serial hemoglobin and renal function tests. So I'm moving on to pancreatitis. So gallstone and alcohol misuse are the most common causes of pancreatitis, coming in at 80%. The diagnostic parameters of pancreatitis, we've got epigastric or left upper quadrant pain that radiates to the back, chest, or flank and is often severe. Serum amylase greater than or equal to 3 times on the high end of normal. Serum lipase greater than or equal to 3 times the high end of normal. 2 of 3 of these have to be present for pancreatitis to be diagnosed. For mild pancreatitis, you've got an absence of organ failure and local or systemic complications. For moderate moderately severe pancreatitis, you have no organ failure or transient organ failure, which is defined as organ failure for less than 48 hours, and then it functions again, and or local complications. Then we have severe pancreatitis, which is persistent organ failure that may involve one or more organs. Risk factors for severity, you've got increased age, obesity, hypovolemia, altered mental status, comorbidities, SIRS, pulmonary infiltrates or pleural effusions, and organ failure. Nursing responsibilities related to pancreatitis are fluid resuscitation. Lactated ringers is preferred and brings about better outcomes, but we don't give it if they have hypercalcemia. Then we'll just use normal saline. For pain management, we do high dosages of analgesics because they're in a lot of pain. For our assessment, we're going to monitor their respiratory status because of all the pain meds. We're going to watch for fluid overload. They'll have abdominal pain. We need to assess that. Their hemodynamics and watch for the SIRS signs because infection can occur easily. Then we're going to anticipate cultures being ordered. We're going to prepare for the ECRP. This is bile duct obstruction removal, and it's done endoscopically with an endoscope, whatever. Following the ECRP, we are going to do, we're just going to monitor for complications. We're going to provide nutrition. They prefer that it is provided enterally, so TPN is our friend here. TPN maintains the intestinal barrier, eliminates complications such as sepsis and metabolic abnormalities, has decreased rates of infection, can modify the stress response and reduce duration of disease process, and has fewer overall complications and decreases the hospital stay length. So for the last and final video, I will go over the endocrine, sepsis, and burn sections. The sepsis and burn will be in depth, and the endocrine will be a short review. I hope this is helping you guys. It's sure helping me.